Good morning, everyone. I'm Allocated. I'm one of the internal medicine chief residents this academic year. It's my pleasure this morning to introduce Dr. Jay Malone. Dr. Jay Malone is an assistant professor of pediatric critical care medicine at St. Louis Children's Hospital and an adjunct assistant professor of healthcare ethics at St. Louis University. He obtained a Master of Science in Healthcare Ethics from Creighton University and a PhD in Healthcare Ethics from St. Louis University. He is the medical director of ethics for St. Louis Children's Hospital, where he is also the chairman of the Hospital Ethics Committee. Dr. Malone is the section leader for medical ethics and health policy at WashU School of Medicine, where he directs the ethics curriculum for medical students throughout their training. Over the past year, he has been serving as an ethics advisor for the local and regional COVID response. Today, he will be speaking with us about the ethics of COVID vaccine distribution. Thank you so much, Dr. Malone.
Thanks, Ava. And thank you to Dr. Frazier and the Department of Medicine for allowing me to be here today and speak with you guys. It's a pleasure to be back and continue this conversation about ethics related to COVID-19. I have this disclosure that I have a speaker's honoraria. I don't plan on discussing this particular organization during the course of my talk today. So at the outset here, I just want to mention that the approach to picking a best allocation strategy for COVID-19 vaccines is multifaceted. And the CDC guidance around vaccine allocation points out that a successful strategy needs sound science, sound implementation strategies, and good ethics. Today, I'm just going to be focusing on the ethics portion of this. But as I get started here, I do just want to take a second at the beginning of my talk to say a huge thank you to the teams of people at BJC and WashU who have been working through this process of actually implementing and operationalizing the distribution of vaccines. It may not be totally obvious to everyone, but there are huge teams of people putting in immense amounts of work on successful vaccine distribution. And so I just want to say thank you to them. I probably don't have time to name all of them, but a huge amount of work is going into that. So a big thank you to those folks. So how are we going to get at this today? First, I want to go through a few past approaches to pandemic vaccination. We have a few examples to draw on from past influenza vaccination campaigns, and those sort of lay the groundwork for where we end up with COVID vaccine allocation. And then I want to sort of go back to an overarching topic, which are the major sort of ethical approaches to just allocation of resources. It's helpful to review those because then we will go through a few proposed frameworks for COVID-19 vaccine allocation, and each of those frameworks that have been drawn upon at various times during the vaccination rollout, each of those frameworks rely to varying degrees on those different major ethical approaches to justice. But as many of you guys know, ethicists love to start with a case as a point of discussion and to set the tone. And I also happen to be a pediatrician, so we pediatricians have thought a lot about vaccines before COVID. So I just want to tell a quick story that I think helps to set the stage for why we need to involve ethicists in vaccine decision making. Many of you will recall in the sort of late 80s, early 90s that we had a spike in measles cases in the United States. Of course, when the measles vaccine was introduced in the 60s, case rates plummeted, and there have been sort of isolated spikes in case rates since that time. But in the late 80s, early 90s, there was a spike in cases. And around that time, the CDC had been sort of playing around with the vaccination protocols for children. Should it be 1 dose? Should it be 2 doses? What should the vaccine titer be? And that was because we were having an emerging understanding of maternal antibody persistence after birth. And so changes were being made to the vaccination protocol. And in developing countries, high titer measles vaccines were being administered on an experimental basis. And in particular, there was one vaccine called the Edmonton-Zagreb vaccine. And the CDC, on seeing this sort of spike in cases, decided to test that vaccine in the United States. And what they did was they went to sort of poor areas in Los Angeles, and they approached families and said, we want to get you vaccinated for measles. You're going to get one of two vaccines. One of them is licensed in the United States. One of them is licensed in other places in the world, but not in the United States yet. And you won't know which one you get. And they signed up over 1,000 African-American and Hispanic families to enroll in this study. What they didn't disclose to those families was that they were also testing varying titers of the Edmonton-Zagreb vaccine. So some children were receiving a dose of approximately 500x the typically used vaccine amount. This study was halted in 1991 because the developing countries that had been using the high titer dosing started noticing an increased death rate in girls specifically who were receiving high titer vaccine. And eventually the CDC came out and apologized for performing this study without disclosing to parents the nature of the study. And of course, this is important because it sort of sets the tone, sort of contributes to the national story of unethical research that's been performed, particularly in low SES communities of color. And even if you're not familiar with this particular case, this has become sort of sadly familiar refrain. So why mention it now? Well, one, it helps to set the tone for some of the equity concerns that ultimately will be very important for COVID-19 vaccine distribution. Two, I think it helps to illustrate the importance of involving that sort of ethics portion of the tripartite approach to vaccine distribution. So let's launch into what our country has done with pandemic vaccine response. Since basically the 70s, planning for response to infectious disease pandemics, which have been almost exclusively those caused by influenza, this has been basically a continuous public health mission for the United States. But in 2003, the urgency of that mission really picked up steam because we had the sort of dual emergence of influenza H5N1, as well as SARS, another coronavirus. And I'm sure many of you remember this happening in 2003. And during past pandemics, during the 1957 flu pandemic, during the 2009 flu pandemic, the CDC has allocated vaccines to states in proportion to their population. However, in 2003, there began to be some thought about directing vaccine to priority groups, to specific subpopulations who would get priority for immunization over other populations. And ultimately, in 2008, the CDC released a document called Guidance on Allocating and Targeting Pandemic Influenza Vaccine. And the development of that guidance was largely prompted by ongoing concerns about H1N1 or H5N1, excuse me, avian flu, which was being tracked and was widely circulating in birds in Asia and Europe. And so basically the CDC put together an interagency expert panel and solicited broad stakeholder input in order to try to identify subpopulations that would be highly prioritized for influenza vaccine. And the final document contained 5 tiers. This tier system is something that has persisted through various CDC documents and into the coronavirus vaccine distribution documents. They also included a pandemic severity index that was meant to help take into account underlying disease dynamics during the allocation process so that vaccine could be targeted in real time to places where pandemic severity was worse. But under this framework, the first tier included about 24 million people. It included pregnant women, infants, and toddlers. And those two groups for influenza are at higher risk. That's not the case in coronavirus, of course. But they also prioritized deployed military, critical healthcare providers, which is not all healthcare providers under this guideline, first responders, and manufacturers of vaccines and therapeutics for influenza. Tiers 2 and 3 then captured the sort of other essential employees, national security personnel, all the other healthcare providers. Of note, and this got changed in a later draft, pharmacists and pharmacy techs under this original guidance were in the tier 2 healthcare providers. They get moved up to tier 1 in later guidance, as I'm going to mention. And then tier 4 is where we got to high risk adults and the elderly. That group has been moved up quite a bit in the coronavirus response based on the particularities of the coronavirus infection epidemiology. And then tier 5 was the remainder of the population. In 2009 then, shortly after this, this guidance came out, a novel strain of influenza was diagnosed in a few children in California. That strain ended up being H1N1. As a pediatrician, I remember this year very well because this particular pandemic hit children pretty hard. And this ultimately was the first influenza pandemic in over 3 decades. Now, we had the 2008 guidance on how to distribute vaccine, but that guidance was essentially too new and never got fully implemented during this 2009 pandemic. But the CDC estimates that this particular pandemic infected probably 60 million people. There were a total of, in the United States, about 250,000 hospitalizations and 12,000 deaths. So compared to what we're seeing now, quite a mild pandemic. But during that pandemic, a monovalent influenza vaccine was developed and distributed to states. And that mass vaccination program is our sort of most recent real world experience with allocation and distribution of a pandemic vaccine until we hit 2020. So in the run up to the 2009 mass vaccine campaign, the ACIP, the Advisory Committee on Immunization Practices, recommended the groups that you see up on the screen, which totaled about 159 million people. They also provided guidance for how to narrow that group in case there weren't enough vaccination doses to cover 159 million people, which there weren't at the beginning of that campaign. And so they narrowed the age ranges on children that qualified for the vaccine. They narrowed it down enough that they got from 159 million high priority people down to 42 million people. So a pretty big cut based on available vaccine. So this is sort of our most recent real world experience with pandemic vaccination, and the 2009 experience helped us to develop the 2018 guidance. That sort of interim time period was used for information gathering and sort of debriefing of the 2009 pandemic. And in 2018, the CDC released guidance that updated and superseded their 2008 guidance. So this document is currently available. And as I mentioned previously, they added pharmacists and pharmacy technicians to tier 1. They also added planning considerations for 2-dose vaccinations and distributions of adjunct agents. Now, why is all this important for us today? Because in June of 2020, Operation Warp Speed, which is of course the coronavirus response, stated their intention to use the 2018 CDC influenza guidance as the foundation for their COVID vaccine distribution recommendations. And that was an important statement because it started to reveal how this vaccine distribution was going to occur, gave us the sort of early look at the tiered approach to vaccine distribution that we ultimately ended up with. So now let's back up and just look a little bit at sort of the ethical principles that underlie these choices about who should get the vaccine first. So the big question really is, who ought to get vaccinated first when a vaccine is available? People have all sorts of different claims to the vaccine. And ethicists could probably come up with a very long list of different claims that people might have. Some people claim reciprocity, that they're essentially owed something. This is true in things like military funerals. That's an honor that's granted out of reciprocity. We owe something special to people who make particular sacrifices. So some people make reciprocity claims. People working in ICUs, for instance, might try to make that type of claim that they deserve the vaccine. Of course, people working in ICUs could make claims for different reasons as well. People might claim that they have a higher risk of morbidity or mortality and that should entitle them to the vaccine sooner. People might claim that they have increased value to society because of the job that they do or a role that they have. And there are many more than just these three that I've mentioned. So an ethicist might rephrase the question, who ought to get vaccinated first, as who has the greatest claim to receive the vaccine? And that ultimately is a question of justice. Bioethicists are familiar with many different principles of just distribution. There are several sort of major principles of just distribution, and I'm going to review those today because each of those feeds into a framework that's been developed around COVID-19. And so those major principles are utilitarianism, egalitarianism, and prioritarianism. Don't get turned off by the big words. We're going to go through these in a bit of detail, but each of these has, of course, proponents and detractors. There's good things and bad things about each of these systems of distribution. But I'm going to tell you a little bit about each of them, and then we'll review some frameworks that use these to varying degrees so that you can get a sense of which systems sound to you like they provide for the most just distribution of resource. So utilitarianism of these three is the one that most people are usually a bit familiar with. This is simply the idea of the greatest good for the greatest number of people. It's an old idea, and it's a familiar idea. And in medical care, this gets operationalized as the idea that we should try to save the most lives with our available resources, or save the most life years with our available resources. Those of you who heard the talk that I gave about ventilator allocation might remember that part of our regional approach to ventilator allocation was to think about how we could save the most lives with the available ventilators that we had. And so utilitarianism has made its way into resource allocation decisions for other aspects of the COVID-19 response already. There's a common objection to utilitarianism for resource allocation, which is, we could call it the fairness objection. And the idea is basically that if you just try to maximize life years saved, you're going to exacerbate inequality. And you could think through this with an example, something like people who are the most likely to benefit from therapies are those with the best baseline health. They're going in with the best health situation. They're more likely to have big benefit and to live longer once they accrue that benefit. So utility says those are the people we should treat. We want to accrue the maximal benefit possible. Unfortunately, what that does is it deprives people with poor baseline health. And so it tends to entrench the inequalities that already exist in a system. So there's an objection to utilitarianism based on fairness for that reason. Egalitarianism tries very hard to address that. It focuses heavily on equality. Egalitarian systems are all about fairness, and fairness actualized through equality. And so they actively rule out discriminatory criteria for distribution. There are some utilitarian distribution principles that try to add in something about equity or equality, but egalitarianism does so in a very active way. The common objection to this is that if you view equality as desirable just in and of itself, just equality is better than inequality under any set of circumstances, that seems to make it acceptable to worsen someone's situation in order to increase equality. And that's called the leveling down objection. I think the sort of easiest way to envision this is just to imagine a universe with two people. One person you can imagine has everything they want for nothing. They have a happy existence with tons of resources. The other person is just living a horrible, hellish existence. And if you could somehow redistribute resource from the well-off person to the less well-off person, you would decrease the good of the well-off person and increase the good of the less well-off person, while not really changing the overall amount of good in this universe. That seems to pass muster. That seems to make sense, that you're maybe taking away from someone else, but you're raising up another person. The objection that people raise, though, is what if you made these people more equal just by removing resources from the well-off person? So now you've made them closer together in how much resource they have available or their overall happiness level, but you haven't actually helped anyone. You've only made them more equal by hurting someone. And that people view as an objection to egalitarianism. Egalitarians might rightly say, hey, actually, there is at least one good thing about that, which is you've increased the amount of equality in the system, and that's a good thing. So that's something that you have to think about with egalitarian systems. And then the third thing is prioritarianism. Prioritarianism is the idea of giving resources to the worst off. This is subtly different than the other two systems. It's an attempt really to combine the well-being maximization of utility with the priority for the worst off of egalitarianism. The common objection here is that it doesn't provide any guidance whatsoever on how to choose among the worst off group if there's insufficient supply for the whole group. So there's no way to choose once you've selected the group of who you believe to be the worst off. There's no way to sort of parse out who's the greatest among equals, if you will. Now you could certainly create some sort of compound system where you said, we're going to use prioritarianism, and if we have too large a group of worst off, we're going to use this other system to determine how to distribute resource among them. But in and of itself, prioritarianism has this particular issue. Superficially, it can be a little tricky to sort out how prioritarianism and utilitarianism might treat medical resources differently, because they both want to maximize good. This is pretty simple to illustrate if you sort of imagine two hypothetical groups. Say group one has an average life expectancy of 75, but a new therapy might increase that to 80. So a net gain of 5 years per person, 5 life years. Group two has an average life expectancy of 60, and that therapy will increase their life expectancy to 65. So also a 5-year difference. Utilitarianism doesn't give clear guidance about what to do here. I mean, the net increase in good, if you imagine good solely as years of life, is the same between the two groups. Prioritarianism would very easily decide to give the therapy to group two because they are worst off at baseline. Then if you change the outcome slightly, you leave group one the same, they still get 5 years out of the therapy, but group two only gets 4 years out of the therapy. Utilitarianism then would say, give the therapy to group one. It creates more net benefit to this system. if you imagine that years of life gained are the net benefit. But prioritarianism would still say, no, we should give the therapy to group 2. You can follow this type of example out and come up with all sorts of weird conclusions that don't really tend to happen in the real world. But the point of this is just to illustrate how utilitarianism and prioritarianism might arrive at somewhat different conclusions in quite similar situations. Medical ethics tries to bring all of this right down to the ground, because in medical ethics, we actually have to make decisions that impact people. We can't just sort of wax philosophic all the time. And so there are many good texts about medical ethics, but the sort of most clear articulation of these principles of justice is in Principles of Biomedical Ethics by Beecham and Childress. And this book is probably one that was used to teach many of your ethics classes in medical school. It's a very well-known book. The approach that's articulated by Beecham and Childress is meant to be objective and authoritative, but not absolute. So it's modifiable to different situations. And their idea is that we should be able to identify a common morality. We should be able to put together a group of stakeholders and decide what's most important. And then for each individual case, we can weigh different ideas of justice against one another to resolve conflicts. So this approach helps to provide a way to take those other 3 sort of principled, lofty approaches and really drill them down to actionable plans. So what I'd like to do is look at a few approaches that have done that, have taken one of the sort of lofty approaches and drilled it down to a practical, actionable set of guidelines. And so I want to review 3 approaches that have been distributed. The fair priority model. The fair priority model was published by Zeke Emanuel, who is now one of President Biden's advisors for the ongoing COVID-19 response. He's an ethicist. Then we'll talk about the Johns Hopkins interim framework for COVID-19 vaccine allocation and distribution. And then we'll finish with the National Academies of Science framework. And of course, this one is of particular importance because the National Academies of Science advise the CDC Advisory Committee for Immunization Practices. So it's likely, and in fact, it's true, that the approach adopted by the NAS ends up being very similar to what we have on a national scale now. Okay, so the fair priority model, this was published in September last year in Science. And this is an egalitarian paradigm model. So remember that the egalitarians are all about fairness and equality. So this model really seeks to avoid vaccine nationalism, which is what we're seeing play out right now. We know that currently about 125 million doses of vaccine have been administered worldwide. Something like 75% of those have gone to 10 countries that make up 60% of the world's GDP. And there are currently 130 countries in the world where 0 doses of vaccine have been administered. That's a problem. That's a problem not just for those countries, but for all of us, because of the sort of interconnectedness of the world, among other just ethical concerns about equal concern for human beings. But we can't sort of eradicate a global pandemic while we have 130 countries that aren't getting any vaccine. So this model really seeks to avoid that sort of nationalism where different countries keep all the vaccine to themselves. And they name 3 primary values. They want to limit harms, they want to benefit the disadvantaged, and they want to recognize equal concern. That's equal concern of people across national boundaries. And they point out that these are universal ethical values, which means that we shouldn't limit them arbitrarily by national borders, which is what we tend to do. They lay out this vaccine distribution plan in 3 phases. They first want to target the reduction of premature deaths, then move to reduction of economic and social deprivation, and then move toward return to full function. So developed countries seem to be focusing right now on how do we just return to full functioning, while the developing world is still focusing on reducing premature deaths as their basically only focus. So in phase 1 of this type of plan, the idea would be to try to distribute vaccines in order to increase standard expected years of life lost. They want to reduce foreseeable premature deaths. And that gives weight to premature deaths, yes, but it also recognizes equal moral concern by valuing a life saved at a given age as identical across countries. So they would therefore want to give vaccine to countries where you would have a greater reduction of standard expected years of life lost by giving vaccine. In the second phase, they change their focus to reduction of economic and social harms, which they think about in terms of gross national income changes. So the sort of ethical importance of this phase is that they think about harm as being more than just morbidity and mortality. They also widen that view and say we also need to consider economic, social, and health deficits. And so we need to give priority to the worst off by prioritizing people in poverty. So therefore, they would then, in the second phase, prioritize giving vaccines to countries where poverty could be reduced by a greater margin. And then only in the third phase do they focus on returning to full functioning. So at this point, they would then basically rank countries by transmission rates and distribute vaccine to countries with highest transmission rates. They don't completely write off the idea of some nationalist concern that developed countries would want to treat their healthcare infrastructure and at-risk populations, but they do suggest that once a particular country's R0 is less than 1, they're controlling the spread of the vaccine. There's an ethical imperative to distribute additional vaccine to the developing world. So just yesterday, the World Health Organization put out a very brief statement suggesting exactly what the fair priority model suggests, which is that the world is either going to win together or lose together when it comes to a global pandemic, and that if we don't control COVID spread in the developing world, the emergence of variants is going to rapidly become a problem for the developed world again. And so there's not only a moral imperative, but an actual imperative in sort of concrete terms to controlling the spread of the virus in the developing world. So this statement calls on the developed world to begin redistributing vaccine to the developing world, and also for vaccine manufacturers to generate equitable distribution plans worldwide. It doesn't seem like probably the right situation that each of our arms has more vaccine in it than 130 countries around the world. So that model is an egalitarian model, and it's one that we could still shift toward. The Hopkins Framework is a shift from that. The Hopkins Framework is in a prioritarian ethical paradigm. And so remember, the prioritarian paradigm focuses on giving resources to the worst off. Their model is sort of implicitly focused on the United States. They don't make an explicit statement about what the Emmanuel paper focuses on, which is worldwide vaccination. But they do name 3 primary values. One is the common good. And I mentioned that common morality is sort of a common thing to appeal to in medical ethics considerations of justice. And then they focus heavily on equity and fairness and legitimacy, trust, and ownership. And legitimacy, trust, and ownership is envisioned in the Johns Hopkins model as the only way that we can actually produce equity and fairness, because without legitimacy, trust, and ownership, communities that are currently the hardest hit by the COVID pandemic won't actually accept the therapies that might truncate the amount of cases that they're seeing. So they develop a two-tier system, which is an interesting system and fairly paradigmatic of a prioritarian approach. The first tier gives priority to people in degrees, the most essential to sustaining the ongoing response, the people at the greatest risk of severe illness and death, the most essential to maintaining core societal functions. Tier 2 is much more categorical. You either sort of are or aren't in a tier 2 category. It's those involved in broader health provision, those with barriers to care if they become seriously ill, those contributing to core societal functions, and those living or working in conditions that increase infection risk. And the interesting thing about this, and why I say it's paradigmatic of a prioritarian model, is that the first tier can be modified based on the supply of the vaccine. So what's currently meant by the most essential workers could be expanded or contracted based on supply. Tier 2 is, it's not completely categorical, but it's more categorical than the first tier. And as I said, this sort of typifies the attempt to combine giving priority to the worst off while also maximizing benefit. The Hopkins Framework does a really nice job of recognizing significant barriers to distribution, which includes public hesitancy to get vaccinated. We can see, and there's a ton of surveys that demonstrate similar data, that some of the communities that are the hardest hit by the COVID pandemic are saying that they're the most resistant to get the vaccine. So we see that 43% of Black adults say that they want to wait and see before getting the vaccine. That's only 26% for white adults. And that difference makes sense when you consider things like the Edmonton Zagreb measles vaccine trial and a whole litany of other sort of medical interventions in the community that have deprioritized Black and brown people. But it puts us in a situation where the people who are being the hardest hit by the pandemic also have the least trust in the system that might be able to help them. So the Hopkins protocol does quite a bit of work to try to think about how that might be reconciled. The third framework is the National Academies of Science framework. And as I mentioned before, this is an important one for us to think about because it's the one that provided guidance to the ACIP, which produced the actual framework that we're using to distribute vaccine right now. This is a clearly utilitarian paradigm. They say outright that they want to maximize societal benefit by reducing morbidity and mortality. And that's a very greatest good to the greatest number approach. It's very utilitarian. So we'll see how this is different than the egalitarian or the prioritarian models that we just looked at. So they list a bunch of primary values. Maximization of benefits, that's the very utilitarian primary value. And I would suggest that that probably should be considered the only primary value in their framework. The other values are, I think important in their framework, but secondary to maximization of benefits. They also mention equal regard, mitigation of health inequities, fairness, using evidence-based medicine, and transparency. So this framework is very science-based. They want to empirically determine risk using evidence-based methods. And they define risk as sort of 4 types of risk. There's risk of being infected, which would include living or working in close quarters or in close proximity to infectious materials. Risk of severe disease if infected, So that would include the elderly or those with many comorbid conditions. The risk of negative social or societal impact if infected. So if we lose healthcare workers or essential workers, that has an outsized societal impact. And the risk of disease transmission. So they sort of consider actively where the disease hotspots are and what people might be sort of moving or commuting in and out of those disease hotspots. I would suggest, and the fingers crossed approach to equity is my terminology. That did not come from the National Academy of Sciences. So I think that this protocol sort of takes a, we hope it all works out, fingers crossed approach to equity. And they do talk about equity, and they say that they make an assumption that disparities will be alleviated indirectly through this protocol. So for instance, they say that by prioritizing people with more comorbid conditions, the framework indirectly gives increased priority to minority groups who have higher rates of those conditions at baseline. But they don't actively try to produce an equitable outcome. They just say, we think that the way that we're targeting the resource, we will alleviate inequity indirectly. They do say, if more vaccine goes to members of one population group than another, it will not reflect who they are, but what they do and what has happened in their lives. And this statement to me, I think, is saying we're not going to target population groups on the basis of their identity. We will target it based on the sort of events of their life and use that as like a secondary marker for what their identity is. So it's a sort of passive approach to equity. But they end up recommending this tiered approach again, and this is based on the 2008 and 2018 influenza pandemic response frameworks. So their tier 1 is broken down into 1A and 1B. 1A is first responders and high-risk workers in healthcare facilities. We've already seen that tier largely play out. Tier 1B is people with significant comorbidities and older adults in congregate living. And then tier 2 moves into a pretty huge group of all older adults. This is the 65 plus group, teachers, school staff, critical risk workers, people with moderate comorbidities, people in group living situations. And that in their protocol includes shelters and halfway houses, but also prisons, and it includes incarcerated prisoners and also prison workers. And then tier 3 is young adults and children. That then advised the Advisory Committee on Immunization Practices, who basically produced a guideline that looked a lot like the National Academies of Sciences recommendations, with some sort of renaming of the phases. I remain uncertain of why it's phase 1A, B, and C and not 1, 2, and 3, but that's just a semantic difference of opinion, I suppose. But this looks a lot like the sort of highly utilitarian approach that was advised by the National Academies of Sciences. So the big question then, because this is the approach that we have in practice right now. So the big question is this approach to equity sufficient? And many people have written beautifully about this topic and pointed out that the outcomes for COVID-19 have been racialized. And so we have to assume that the response to that ought to be actively anti-racist. But the CDC talking points about how they developed the ethical thinking around these points of equity are very confusing. They both describe how their criteria might help to mitigate inequality, but then they also describe how they might worsen inequality. So they say things like, for the example of persons with high-risk comorbidities, they point out there's an increased prevalence of some medical conditions among racial and ethnic minority groups. And so targeting persons with high-risk comorbidities will help in terms of equity. And then they say, but at the same time, diagnosis of medical conditions requires access to healthcare, and access to healthcare is worse among racial and ethnic minority groups. So it's also, they say it's also possible that our approach will inadvertently worsen inequity. They don't parse how that ought to be addressed. They do basically say, we hope that this works out okay. We can see in cities that have good tracking projects how this is actually working out. So I couldn't find this for St. Louis, but this is Chicago. So close enough to feel relevant, I think. And I imagine that this very closely mirrors what you would see in St. Louis. On the one hand, you can see COVID-19 deaths per capita by zip code. On the other hand, you can see completed COVID-19 vaccinations per capita by zip code. And it's striking how the vaccine distribution is focused on areas with the lowest rates of deaths. Now, what I didn't actually do here was do the racial overlay, but I think you can imagine it. It looks a lot like the COVID-19 deaths chart. If you were to overlay communities that are higher percentage Black, it would look a lot like that deaths chart. There was an early sort of guess about this pattern emerging that the completed COVID-19 vaccination density was around areas where there were hospitals. So like you can see there's a huge density around downtown. The sort of zip code further south is Hyde Park, where there is also a hospital. That's sort of the one area on the south side there where there are still more white than Black residents. But this, even after we've left phase 1A and entered phase 1B, where presumably it's not just healthcare workers getting vaccinated, this sort of difference has continued to broaden, and it seems less and less likely that this is just because of healthcare workers getting vaccinated. So I think that this helps us to understand that a passive approach to trying to ensure equity in this system is insufficient. That is, I think, probably not surprising to a lot of people who have been living this for a long time, but it's worth pointing out. There was a very nice recent editorial that talked about this idea, and they point out in this editorial that we're now moving into a phase of vaccine distribution in which we're leaving behind the sort of assessment of comorbid conditions and granular consideration of risk, and we're moving into a much blunter tool, which is age. We're beginning to distribute vaccine around the country based on age. And the authors in this editorial point out that booking vaccine appointments requires three important resources, which are time, technology, and trust. And those resources are not equitably distributed among our population. So if we move to a blunt response without an active approach to equity, we are without a doubt going to continue to worsen the divide that we're seeing in who's receiving vaccine and who's not. I would add to their list of unequally distributed resources of time, technology, and trust that age itself right now is not equally distributed among our population. And up on your screen now is, this is a few years old, but this is average life expectancy from birth for St. Louis County. And you can see the gray area in North County is the sort of range of about 56 to 77. The blue is 77 to 81. And the sort of purplish is 81 to 91. The distribution of vaccine by age, you can easily imagine that if you distribute vaccine to people aged 75 or greater, or even 65 or greater, that more of that vaccine is going to places like West County, which are more affluent and more white than places like North County, which have worse access to medical care and higher rates of comorbid medical conditions. You can see there are some zip codes like 63140 where the average life expectancy is 55.9, compared to some areas in West County where it's in the 90s. That zip code in North City, where the average is 55.9, is 97% Black. And so you can start to see that even age itself is not equally distributed in our society. So without an active approach to equity, there will be an increased divide along these lines. So what can we do? Well, I've got a few points of guidance that constitute guidance that's not our decision to make. One, we really should prioritize vaccines to zip codes that have high indices of hardship. And there's a variety of different ways to quantify the hardships that are experienced by people. One is area of deprivation index, which is a metric that charts a variety, like 17 different indicators of well-being. And if we prioritized vaccine to those areas that have high indices of hardship, we would be doing a better sort of active job of providing for equity. Vaccine manufacturers should probably start to seriously consider the egalitarian approach proposed by Zeke Emanuel and allocate vaccine fairly on a global scale. And ideally, I don't think this will happen, but ideally they should share their science so that others can start producing effective vaccine more rapidly. And then countries that have vaccinated their highest risk individuals should start to allocate their vaccine to developing countries. The practical guidance that is up to some of us, well, one, get vaccinated when you're eligible. There are almost certainly some people on this call right now who have elected not to get vaccinated. And that's a problem for a few reasons. One, because it's just good for you to get vaccinated. But two, because as I'll point out in a moment, physicians have an incredibly important role in assuring societal trust. And when we choose not to get vaccinated, if our patients ask us about that and we express hesitancy, the trust that they have in us will immediately take on an important role in their understanding of the safety and benefit of the vaccine. So we should all deeply want to be able to tell our patients and their families that, yes, we got the vaccine as soon as we were eligible. We should also include community members in our planning groups. Community members are going to be helpful to us in a variety of ways, one of which is helping us to know the best places to target vaccine distribution, but one is helping to generate community trust, which is not a simple task. Community outreach, therefore, should focus intentionally on the areas that have been hardest hit by the COVID pandemic, and that should involve community leaders. There are a variety of different cities around the country who have done things like enlisted pastors from the largest churches in the hardest hit areas to publicly receive their vaccine in order to generate trust among the people that live in those areas. It's a great idea. And this sort of intentional community outreach is really important. And then I'll leave you with this sort of idea that primary care physicians and community pharmacists have an incredibly important role. One of the reasons that West Virginia has one of the highest vaccination rates in the country is that they're allowing independent pharmacies to take a very active role in distribution of vaccine. And that's not CVS and Walgreens, it's independent pharmacists who have a healthcare relationship with patients. When you ask people who they have a great deal of trust in, across the board, cutting across different socioeconomic factors, people trust their own doctor. So they trust you guys more than Anthony Fauci, which is amazing. So the role that internists play in helping their patients to feel like they can trust this vaccine and to get the vaccine is incredibly important. So I'm going to stop there and entertain any questions that people have.
Thank you so much, Dr. Malone, for walking us through all of that. Everyone who's here, you can go ahead and submit questions through the Q&A or the chat if you'd like. We have a couple minutes for questions. I'll go ahead and start and ask, a lot of what you discussed and a lot of the vaccine rollout currently is with the 2 vaccination series with the mRNA vaccines. Are you optimistic that some of these questions of equity and benefiting good and access will be a little bit easier to execute with the future 1-dose vaccines that don't require the same sort of temperature control that the mRNA vaccines currently require?
Yeah, so I guess I have just a couple of brief responses to that. One is that cold chain storage is a major consideration for vaccine administration in the developing world, of course. Now, many of the countries that have yet to administer any vaccine have demonstrated that they've established cold chain and are ready to accept the available vaccine that exists now. So I would hate to write off the existing inequity by just saying it's a cold chain storage problem, because it's not. 2 is there's sort of a big question about the 2-dose vaccines that are currently being given. Moderna and Pfizer have efficacy demonstrated in the 90%. The single-dose vaccines have lower demonstrated efficacy, though of note, they do seem to prevent severe disease and hospitalization and death. But we I think run the risk of creating the appearance of an equity problem if we say, okay, we're going to give the less effective vaccines to communities of color for whatever, even if we explain like, okay, it's an issue of distribution, rapidity of vaccine allocation. I think that we will create an optics problem if we just target the single dose vaccine to harder hit communities. So I think it's still important to involve community leaders in this decision making so that we can actually ask people who live in those communities, like, which vaccine is the best for your community? What would your community members be able to get behind and accept? That sort of community-based approach is probably the best option for that.
Okay, thank you for that. One question that came in, so they thank you for a great informative presentation. They asked, one of the concerns about vaccines is that they help to minimize symptoms and death, but do not improve, or we don't know about infectivity. This calls into the question the entire concept of herd immunity, as vaccinations simply serve to increase or could serve to increase the number of asymptomatic carriers. Should this factor into vaccine distribution? So
I don't want to stray too much into like trying to interpret the science, though it's the data about infectivity remains unclear to me. I don't think that it's clearly established that the vaccines don't improve infectivity. And I don't think I'm ready to regarding herd immunity. I think that I guess where I'll say without, I'm trying not to dive into the science, but I think that we're seeing some encouraging changes right now in the trends of national cases, hospitalizations, and deaths. Now, we're still not nearly out of the woods. We still have something like 2,400 deaths a day, but we're way off of our peak. And part of that seems to be because between people who have been infected, which is probably over 100 million people, and people who have been vaccinated, we're up to something like 45% of the population that has either been infected or had at least one dose of vaccine. And that seems to be impacting case rates nationally. So it's not clear to me that the premise of the question is right. I don't think that the vaccinations are probably just serving to increase number of asymptomatic carriers.
Yeah, okay, got that. And then the last question that we'll do today is, so how do we balance equity and speed in vaccine distribution?
Right, well, I guess it depends someone always throws in a really short question that's like super complicated and hard to answer. So I think it's a great question. And I think that the answer to that question probably depends on which of the approaches you want to subscribe to. Some people would say, for the good of our nation, and for the benefit of all of us, we just have to focus on equity. The communities that have been the hardest hit by this pandemic are the communities that we need to focus our response to. And even if that slows down vaccine distribution somewhat, we should still focus our efforts on those communities. So I do actually agree with the sort of premise of this question that we have to find some balance. There's probably an inappropriate answer to the balance between equity and speed, but I guess what I would say is it does not seem to me that faster is better, period, end of story. I think there is some amount of speed that we should be willing to give up if we can amplify equity. So maybe I'm moving away from the strict utility response and into sort of a prioritarian response when I say that.
All right. Well, thank you so much, Dr. Malone, for answering some of these questions that have been coming in this morning. I mean, I agree. This is stuff that is very difficult to answer. So I'm very thankful for leaders like you who are taking the time to kind of help to make a lot of these very difficult decisions. And I think that there's a lot more decisions to come as we, continue vaccine rollout and adopt new vaccines into our toolbox as well. So thank you again.
Thanks very much. I appreciate the opportunity to be here.